Thanks. So we'll go on. We'll have Dr. Abhijeet presenting next, and I'll request the next presenter, Dr. Sheetal Brar, I think. Yes, Dr. Sheetal, to please set up her presentation.
Can we have the slides? So we are going to talk about a novel irrigating CCC forceps. So the idea came from our presentation in which we had done a comparison of viscolis phacoemulsification and versus a soft shell technique in grade 1 to 3 cataracts, and we realized that there is hardly any difference in the endothelium health pre and post the surgery. So it was taken as a very safe technique to be done. So why viscolis cataract surgery is essentially because of the BSS is the most endothelial friendly material, better than even the OVDs. TAS is mostly from viscoelastics. This technique is used in NS 1 to 3 cataracts. Also OVDs trigger IOP spikes and can trigger inflammation in the eye as well. So the challenges for viscolis was mainly the capsular axis, maintaining the chamber during the CCC and the flutter that happens with the flap. And we found it useful even in intumescent cataracts, and this device overcomes these issues very easily. So let's see how that goes. So when we started doing viscolis, this is how we were going about it with the side port and the needle. And sorry. And with that, if you see, it's very difficult to turn and maneuver the entire axis with a needle using just the irrigation. And you can see that flutter which is happening there. And it's not easy to manage the CCC using these, this device. So we thought that maybe the leakage from the side port is the one which was causing this problem. So we tried it with a thicker needle. So when we tried with the thicker needle, even then the problem was the same. The flutter and the management of the rhexis was very difficult. So though it is completed, it's very difficult to manage these things. So we designed a metal prototype with a irrigation attached to the forceps itself, the microvitreal forceps. And we found that worked very well, maintained the chamber very well. But because of the metal, if you see in this quadrant, wherever the forceps is being rotated, you lose the track of the rhexis out there completely. We'll see it again out here. So the visibility at some stage goes away whenever you're doing this, using this forceps, this prototype. And again, many a times this used to come out of the wound, and that used to give a problem. So we used the second prototype in which we designed it as a coaxial one in which we could use the phaco sleeve over the same forceps. And we realized that this was much better. Now here I'm using, these were the initial stages where I'm using the irrigation port, an additional irrigation port, because we were not sure how they would work. And slowly, as we got confident about the efficacy of the flow, we shifted to purely the coaxial ones. And in fact, you can use the second hand with the aspiration port, like what I'll be using here. So this, we changed the design of the tip because we could take the sleeve much more inside, so the flow is much better. And here I'm using the second hand with the aspiration port to support, because all these are topical cases, they give you a good stability. And you have good control, you can move it easily, doesn't give you the flutter that was giving with the irrigation and the cystitome, and you're able to easily complete the rhexis. So let's see how that works in intumescent white cataracts. So here I'm using an additional irrigation to increase the IOP in the eye with a dual in this one. And we've made the first nick. So far so good. So in these cases, I also sometimes feel we can use the aspiration port to, after the nick, to use the aspiration port to remove of the fluid in these cases. And we are able to manage this very easily. And the rexus at no time seems to be going in the periphery. So now here is a grade 4 to 5 brown cataract. And again, the CCC is behaving very well in this, with this instrument. So what does this forceps help with? It's a normal microrexus forceps. You can use it with through the side port as well. You can use your normal phaco sleeve over it. It's another novel technique, and especially for those who want to do viscolar surgery, it's another instrument for difficult scenarios. And it can also be used to peel PC plaques. So you can actually go down and maintain the chamber while peeling off the PC plaques. Thank you.
Very nice, Abhijeet. And I do something similar, but not with such a fancy instrument. What I do is I have calibrated side ports. So I have two side ports. Both are calibrated to my instruments. One will take a 22 gauge infusion, which is my knives are also 22 gauge, which is 1 millimeter. And from the other port, I have a 22 gauge microrexus forceps.
Yeah.
So basically what that does is the same thing as what you are doing. The chamber is stable. So if you don't have any fluid getting lost from the chamber, there's no fluid flow happening, that thing flutter won't happen.
Yeah.
So your chamber is going to be rock steady.
So here the advantage is you can use the aspiration port to hold the flap as well.
Right, I agree. So for me, how that works better is that because I can switch hands with the microrexus forceps if I want to.
Yeah.
Okay. Because suppose I want to access an area
Change
where
the angle,
so I
yeah.
can then access. But the main thing, take-home message from here, I think, is that your chamber should have stable chamber
IOP.
with no fluid loss happening from any port.
Yeah.
And that sets up, and
Yeah.
it's a brilliant innovation.
Thank you so much.
So, any question from Ashish or?
No, I would just like to congratulate Abhijeet. You're an excellent surgeon. I mean, doing this rexus in such a turbulence is not a joke. Excellent.
Thank you so much.
Very nicely demonstrated points.